Welcome, Professor Parati. It is our pleasure and privilege to have you with us on our annual Egyptian Hypertension Society scientific meeting. And your topic will be about cardiovascular impact of obstructive sleep apnea. Professor Parati from Italy. You can go ahead. Welcome.
Thank you. Thank you. I hope you can hear me well.
We can hear you well.
Okay, thank you. I'm trying to share my screen now. Let me see. Okay, can you see the slides?
Yes.
Perfect. So thank you for the invitation and for giving me this important topic, which is one of the new frontiers in cardiovascular protection. These are my disclosures. And well, let's start with this nice Van Gogh painting. That's a night. You can get the feeling that it's something quiet, which is usually the case, but something may happen also for the cardiovascular system here. And key questions are, what happens to the cardiovascular system regulation at night, and what could be the impact of obstructive sleep apnea disrupting this regulation during sleep? This is an intrathecal recording we carried out with Professor Mancha, which I'm happy to see online as well, many years ago. And that these were the first studies in humans where we could demonstrate the occurrence of blood pressure variability, and in particular, during the night, either during the sleep at night or the sleep in the afternoon, you find clearly a blood pressure reduction. That's usual physiology. But things might change in some specific patients. And that's the typical patient we should take care of. Is a male subject, an age between 50 and 60, abdominal obesity. You cannot see, but in the pocket of the shirt, there is a pack of cigarettes, who is a smoker. He was drinking alcohol, as you can see, might have hypertension, metabolic syndrome, diabetes, hyperlipidemia and inflammation, organ damage, autonomic dysfunction, and he's already sleeping. That was a short flight, 30 minutes. So daytime somnolence, which might be due to something wrong happening at night. Indeed, when this person is going to sleep supine, he might have an occlusion of the upper airways. And in such a case, in spite of the muscle efforts, as you can see here in this polygraphic recording, these are thoracic and abdominal muscles. In spite of the effort, there is no airflow because of the occlusion of the airways, which is leading to hypoxemia. This is stimulating the chemoreflex, and you can have a sympathetic activation. And when you start breathing again after a few seconds, you get a blood pressure rise. We did many recordings combining oxygen saturation with blood pressure beat by beat, and you see here 5 minutes of recording with 6 apneas. So this is a severe sleep apnea patient with more than 1 apnea per minute, and anytime you have oxygen desaturation, you see then a blood pressure peak. So this behavior of blood pressure is not healthy and can lead to cardiovascular damage. Indeed, there are several mechanisms behind this. The cycle of hypoxemia, reoxygenation, autonomic dysfunction, arousal and sleep disruption, intrathoracic pressure changes in hypercapnia might lead to a number of changes in the regulation, including inflammation, endothelial dysfunction, metabolic dysregulation, hemodynamic changes as you have seen in the slide, and sympathetic activation, which in turn may favor the appearance of hypertension, arrhythmias, mainly atrial fibrillation, heart failure, coronary artery disease, stroke, pulmonary hypertension, a number of other metabolic disruption, and in the end, mortality. This is the Wisconsin Sleep Core study, one of the most important longitudinal studies on sleep apnea. They included normotensive people at baseline, and you see that over a 4-year follow-up, even a mild apnea, quantified by the apnea-hypopnea index, AHI, even only of 515, which means mild apnea. So even in this case, you find an increase in the risk of developing new hypertension. suggesting a causal link between sleep apnea and hypertension, which was confirmed by this important Spanish study by Dr. Marina and colleagues. They included a large number of patients with a follow-up of 15 years. And again, you find a progressive increase in the incidence of new hypertension as a function of sleep apnea, and in particular as a function of sleep apnea severity. Those with the most severe sleep apnea were having a much greater risk of developing new hypertension. This is disrupting the 24-hour blood pressure profile. You have seen before that blood pressure at night physiologically should be reduced. In these cases, you might still have normal pressure during the day in the office or at home, but you might see a nocturnal elevation, which is related, as you can see, the lower part of the slide, to oxygen desaturation quantified with polysomnography. Again, that's a typical example of nocturnal hypertension, a kind of masked hypertension because it's not visible during the day, which is related to hypoxemia and sleep apnea. And nocturnal pressure is important. That's an old study that we're participating in, Professor Mancha and Dr. Stassen. The Sistio study is an old study, but at that time we were able to have a placebo arm, which gave us the possibility of checking the impact of different blood pressure measurements on events over a 2-year follow-up. Office pressure has only a weak relation to events. A better relation was found for daytime, for the 24-hour, but the best was with nighttime pressure, which is suggesting, and many other studies did, that this parameter is very important in our prognostic assessment of cardiovascular patients. Well, not only hypertension is a consequence of sleep apnea, we should also consider arrhythmias. This shows the incidence of atrial fibrillation over years of follow-up. As you see, the frequency of new AF is much greater in those with obstructive sleep apnea than in controls. And if you follow these people after pulmonary vein isolation, the ablation technique, you find that those who did not fix the sleep apnea problem had a much worse survival curve than those who were removing sleep apnea. So having still apneas, even after pulmonary vein isolation, may favor recurrence of arrhythmia. And not only atrial fibrillation, fortunately also ventricular arrhythmias and sudden death. You see here in this slide on the right, the different percentage of ventricular fibrillation due to several different causes. The white bar refers to obstructive sleep apnea. And if you focus on the night, you find that those with sleep apnea were having the greatest risk of cardiac arrest due to ventricular fibrillation. Another important issue is stroke. There's a nice Swiss study by Claudio Bassetti. You find a distribution of stroke, the black bars, as a function of age. The hatched gray bars refer to the accompanying increasing frequency of sleep disorder breathing, sleep apneas. And if you consider the follow-up of this patient after stroke, you find that those non-surviving were those having the worst sleep apnea condition with the highest apnea-hypopnea index. Again, having sleep apnea may favor stroke and its complication, and that's a vicious circle. Stroke may in turn also worsen the frequency and severity of sleep apnea. Course failure is associated with sleep apnea. That's a register we carried out in Italy years ago with several cardiology centers, and we found quite a high prevalence of both central and obstructive apneas in heart failure, accompanied also with chronic insomnia, which may worsen the prognosis. Indeed, as shown by the Sleep Heart Health study, again, you find that the increasing severity of sleep apnea, quantified by the apnea-hypopnea index, is increasing the risk of developing congestive heart failure over the years in cardiac patients. One of the mechanisms for this frequency of heart failure may be the rostral shift of fluids. When you stand with heart failure, you might have edema in the lower part of the body. When you lie down, this volume can be centralized and shifted to the upper part, including the upper airways, where here it might increase the thickness of the pharynx and facilitate collapse of the airways. What is really important in general in explaining the severity of cardiovascular complication with sleep apnea is not only the frequency of apneas, it's the severity of hypoxemia. The hypoxic burden, which is the percentage of time during sleep that you spend with low oxygen saturation, is a very important prognostic indicator. As you can see here, those in the worst quintile of distribution of the nocturnal hypoxemia were those having the worst survival, because hypoxemia itself was triggering many of these cardiovascular changes. The last point I want to discuss with you is how and whether we can fix the situation by treating sleep apnea. As you know, there is a lot of discussion on the real efficacy of treating obstructive sleep apnea with CPAP. CPAP is a very easy tool. Now we have several nice new technology facilitating this approach. But the question is, are we able to normalize blood pressure and to provide cardiovascular protection by this treatment? Well, let's start with the blood pressure effect of CPAP. CPAP is certainly able to remove the apneas. You improve the apnea-hypopnea index. You improve the autonomic regulation. You remove systemic inflammation, endothelial dysfunction. You improve the arterial stiffness and the metabolic changes. But when you focus on the blood pressure change, that's a meta-analysis we published a few years ago, you find a blood pressure reduction, yes, but only a few millimeters of mercury on average. As you see here, 2.3, 2.4, no more. And what are the reasons for this disappointing small blood pressure reduction? There are several possibilities. First, poor compliance. Our patients don't like to take pills. They like even less to sleep with a mask, and they don't use it basically. So, of course, you cannot see any benefit. We might not have a proper calibration. If you don't calibrate the pressure of the air for each individual patient, you might not get the benefit. Again, you might not use ABPM. If you want to check what happens at night, you cannot rely on office pressure, obviously, because you cannot see what happens at night. But more importantly, probably, the real reason is that we start treatment too late. We diagnose sleep apnea late in the clinical history of the patient, and we start treatment even later, which means when organ damage is already developed, hypertension becomes resistant, and is not only resistant to pills, it's resistant also to CPAP. Just to show you the importance of compliance, of adherence to treatment, you see in this study from Spain again, that those using CPAP at least for 4 hours or more at night did show a much better reduction in blood pressure than the others. So this might help us out. And another important point when you focus on the blood pressure effects is which kind of patient you are focusing on. This is an individual patient data meta-analysis we just published this year in the European Respiratory Journal. It's including data from all over the world, from the main trials. And you find that indeed CPAP was not really changing blood pressure that much in those with a normal pressure, either spontaneous normal or controlled by treatment. The blood pressure reduction was evident, systolic and diastolic, during the office on the ambulatory recordings when you were focusing on people with uncontrolled blood pressure. So that's another important way to look at the results. Last point, what about then CPAP and cardiovascular protection and outcome? Well, you may remember the SAVE study. The study was quite disappointing. They showed that there was no benefit at all by using CPAP in cardiovascular patients in terms of mortality reduction. But in this study, they included severe patients with already evident cardiovascular disease, and their prognosis was poor since the beginning. So CPAP was unable to revert the situation in any way. Another nice study from Korea that was considering people in a less advanced stage of cardiovascular disease, a meta-analysis, showed on the contrary that you might see a reduction in stroke, in cardiac disease and cardiovascular events, and also a reduction in the mortality for stroke, for cardiac disease, and for cardiovascular events in general. So again, the issue is when to start, and how to select the proper treatment in the proper patients. So in conclusion, no way we have to take care of what happens during sleep. the earlier we do this, the better it is. I want to refer to the recent statement by the American Heart Association published in 2022. They were summarizing the so-called life essential 8, which are the 8 components of cardiovascular health. They obviously include a healthy diet, a healthy physical activity, a healthy level of blood glucose, a healthy body weight, a healthy level of lipids, of course, a healthy level of blood pressure, and no smoking. But in 2022, they added also healthy sleep. And sleeping in a proper manner with a proper quantity of sleep and proper quality might change cardiovascular prognosis. This is because if you have these respiratory disorders during sleep, you have a sympathetic excitation, which we know very well is accompanying both hypertension, heart failure, and medical complication. I just want to conclude with referring to the movie. You remember this movie, Sleeping with the Enemy, with Julia Roberts many years ago. Well, that's the case also in case of sleep apnea. It's something which may worsen your prognosis. And we definitely need to diagnose and treat sleep problems and sleep-related breathing disorders early before organ damage develops and cardiovascular damage becomes irreversible. You're welcome to join us in Milano in a few weeks for the SAGE Congress from May 23rd to 26th, where these issues will be discussed again. Thank you for your invitation and thank you for listening.
Yeah, thank you, Professor Parati, for this very informative lecture. I have 2 questions. You mentioned that atrial fibrillation is very prevalent in this type of hypertension. Whether this necessitates doing routine and follow-up search for this atrial fibrillation, for example, by and the second question, you mentioned that ventricular arrhythmia and sudden death are common because of the hypoxia present in this condition. Whether medical treatment by beta blockers in this condition should be preferred than other antihypertensive therapy? Thank you.
Well, thank you for your question. They're a very important question indeed. Thank you for asking them. Concerning atrial fibrillation, we all know how important it is to screen for atrial fibrillation to prevent stroke. That's a major issue in clinical medicine. And we have to identify all possible risk factors for that. And sometimes, well, it's not easy and common to do the polysomnography in all patients. That's actually almost impossible. But if we are properly assessing them with a proper sleep history, and with some simplified recording, for example, ECG plus oxygen saturation, combined with the proper history, we might identify those at higher risk and go deeper with them with a polygraphic recording, because if we identify sleep apnea, we can not only prevent appearance of atrial fibrillation, but also help reducing the dangerous complication of this very, very common condition. And we all know that sleep apnea is accompanying obesity, is accompanying hypertension, is accompanying metabolic disorders, and all these factors are also favoring arrhythmias. Concerning the second question, the ventricular arrhythmia and beta blocker, you're absolutely right. In the ESH guideline, and Professor Mancha was leading this actually, we are still proposing beta blockers as one of the first line treatment for many reasons. And anytime you have a sympathetic activation, and in the ESH guidelines, there is a specific mention of sleep apnea as one of the conditions associated with a sympathetic activation, beta blockers can help. They can help reducing ventricular arrhythmias. They can also help preventing somehow atrial fibrillation. And they also reduce the swings in heart rate, which are very common during night in patients with sleep apnea. There was some concern in the past that beta blockers might worsen the bradycardia that might happen during the apnea phase, but we published a study a few years ago showing that this is not absolutely the case. There is no risk of severe bradycardia, but on the other side, we can prevent tachycardias and arrhythmias. So I think they can be very useful also in this setting.
Is there any specific antihypertensive group that proved useful or effective in this group of patients with obstructive sleep apnea? apart from the possible beneficial effect of beta blockers?
Yes, thank you for asking this again. Well, there are a few studies showing that, first of all, if you have hypertensive patient with sleep apnea and you start CPAP treatment, you should not stop pharmacological drugs because CPAP itself might not be enough, and the combination of CPAP plus antihypertensive agents can be very effective. There is a nice study from Jean-Louis Pepin from Grenoble in France showing that valsartan associated with CPAP was extremely effective in reducing blood pressure. Another class of agents that has been suggested to be very useful is the mineralocorticoid receptor antagonist. Spironolactone has been shown to reduce blood pressure quite effectively in these people because they have inactivation of the renin-angiotensin-aldosterone system and might even improve the quality of sleep by reducing the severity of apneas because it might reduce the level of edema at the upper airway level. So these are some indication coming from recent studies besides the use of beta blockers, obviously.
I would like to ask that this obstructive sleep apnea is usually common in the obese and morbid obese patient. Does bariatric surgery have any impact on the management of this condition? Or any studies have shown that?
Yes, of course, obesity is one of the key factors responsible for obstructive sleep apnea. If these people lose weight, their apnea severity is improving. And there are several treatments that might help us reducing the body weight and in parallel improving sleep apnea. Well, bariatric surgery is one of them. There are a few studies showing that this is accompanied by an important improvement in sleep-related breathing disorders. But now we also have nice data with the new drugs reducing body weight, such as the GLP-1A agonist, that seems to be able to improve sleep apnea as well, besides providing a non-aggressive way to reduce body weight. But in general, any means of reducing body weight can also improve sleep apnea, and we have data on this.
Thank you very much, Professor Parati. And the second speaker will be